Hello, everyone. Welcome back to Neurospicy Nursing. It's your ADHD-friendly study buddy for turning nursing chaos into clarity. Today, we're going to go over some GI as well as the medications, the full assessment, and then I also, since we're covering GI, wanted to talk a little bit about pharmacokinetics, and I'll cover some things about the general survey here as well. So, when we're talking about the general survey, so this is everything that we see immediately when we walk into the room. We're looking at our patient's hygiene, how they're dressed, how they look overall. We're looking at how they carry themselves. Are they slouching? Are they sitting up straight? Are they grimacing? Stuff like that. Um, we're obviously also going to look at their speech. Are they slurring their speech? Can they comprehend what I'm saying? If they are walking into the room, I'm going to watch their gait and stuff like that, how they move around. This is also where when we're going to take their vital signs and their height and weight and all of that. And at this point, we're also going to do that pain assessment. I will be doing a later video that's going to go over everything about the pain assessment. So that PQRST that you've probably heard about in the past. We're going to go way more in depth in it. And then I'm also going to talk a little bit about some medications that we use to help mitigate pain. All right. So for an adult, our normal range for their pulse is going to be 60 to 100. So anything below 60 is going to be bradycardic. Anything above 100 is going to be tachycardic. 100 does not mean that they're tachycardic. 100 is still normal. Now, again, if they are above 100, that is tachycardic. And then when we see the strength scale, what that means is when we're palpating our pulses, when we're doing our head to toe, this is how strongly their pulse feels. 2 is going to be normal. 1 is going to be weak. And some of our elderly patients, a 1 is really, really normal. Um, a 0, that's absent. I do want you to keep in mind, though, if they have an absent pulse, like palpating absent, we're going to look for the Doppler to make sure that they have some sort of perfusion, right? Because just because we can't physically feel their pulse, if they're still warm and their like limb is not cold, we're going to assume that they have some sort of blood flow, right? So that's when we check with the Doppler. Bounding, that's a big red flag. So that's a +4. Normally when we start bounding, we'll start bounding right before our body starts to like shut down, right? Or like if they just did like really intensive exercise, that's another time you see bounding. Or increased if they're a little bit more on the fit side, not me walking up the stairs. Blood pressure for a healthy adult, you want to try to keep it below 120 over 80. It used to be 120 over 80 was like anything above 120 over 80 was abnormal. Now it needs to be specifically below 120 over 80. Um, However, once we start getting kind of for the diastolic, which is that lower number, when we start seeing that below 60, we're really concerned. And when we see the systolic, so the top number below 80, we're going to be concerned. And then it talks a little bit about hypertension stage 1 and 2. You guys don't really know that, but just do know that in order to be diagnosed with hypertension, we have to have 2 consecutive high blood pressures on different dates. So respirations for an adult, 12 to 20 is the normal. Anything above 20, again, that's the Kipnik. Anything below 12 is Brady. So Brady would be like if you just gave a patient a dose of morphine, and let's say the respirations have dropped to 10, that's when we'll see that bradypnea. And then O2 stats, 95 to 100 is really where we want to live at. Obviously, our COPD patients, they're going to live lower than that 95 to 100, and that's their normal. But technically, atypical is going to be anything below 90. Oops, sorry. There we go. Sorry about that. So, like I was mentioning before, so now that we have, this is going to be our patient's vital signs, right? This is us looking at our patient. We have our patient, they have a high fever, so they're hyperthermic, right? Because temperature of 102, that's pretty high fever. Pulse rate, they have a regular pulse rate. They're technically tachypnic right now, and their blood pressure is a little bit high. And then their O2 sats, they're sitting at 95, so that's not too concerning right now. But we can see that visually they look relatively disheveled. They have a body odor. Maybe they're not taking care of they might be suffering from depression, maybe haven't been showering like they're supposed to. But in this case, they have some cuts and bruises and stuff like that. And this patient is confused. So all of this stuff is going to be stuff that we are going to write down in our general survey. We're also going to ask them if they have taken any medications or if they have any allergies, stuff like that. So here's what's really, really important about pathophysiology and why, based on the pathophysiological process, we have certain medications for these, and based on those meds for the disorders, they will have side effects, right? Every medication will have adverse side effects. So for any disease or injury, let's talk really quickly about peptic ulcer disease, right? A very common medication that we see for these individuals to be prescribed is going to be a PPI to help lower kind of that acid level in their stomach. Based on their disorder, we know that that's probably an anticipated prescription that they're going to get. So we have to be able to understand the pathophys of our disorders to be able to click why we're giving them this medication. All right, the other thing that we have to also keep in mind is homeostasis. So when things get all out of whack in the body, our body is trying to help regulate the homeostasis, right? In the case of, let's say, diabetes, right? A normal individual will produce insulin. I think a healthy individual produces up to 44 units of insulin a day. That's normal functioning pancreas. If you have type 2 diabetes, you can't regulate that biological process anymore, right? So then they're going to have to take an anti-diabetic or something like that to help, like metformin, to help lower their blood glucose levels. Or if someone's having a fever, they might be, sweating to help try to bring down that temperature because they're trying to use, well, one, they're trying to regulate their homeostasis, but also evaporation helps cool somebody off. So your body's trying its best to help regulate and maintain that homeostasis. All right. For the pharmacokinetics, before I kind of go into more of like the general survey and stuff like that, and the rest of the GI stuff, um, absorption. So think of I like to think of absorption very similarly to how we put food in our body, right? So we're gonna put food, it's gonna start being broken down in our mouth, right? That's us chewing. We're gonna swallow it, it's gonna get into our stomach. Our stomach has enzymes to help further break down that food to help us, absorb it and then distribute it for it to go wherever it needs to go to help make energy, right? So the same thing is kind of going to happen with drugs. We are going to administer the medication, however we're administering it. Make sure you're reading your order, right? Because you don't want to give an IV push med orally, right? That's going to be bad. It has a different dilution. It might be harder on the stomach. These are all things to keep in mind and make sure that you're doing your medication math as well. So, and also, too, based on the route, it's going to go through something called first pass effect. So, first pass effect is all based on, you know, the liver's ability, because the liver and our kidneys are the heavy hitters for our drugs, right? They're the ones that it's it's really medications are really either liver toxic or nephrotoxic, right? But first pass effect is that the liver, when a medication is administered for the first time, if it's, you know, orally or not really IM, but maybe topical, or buccal or anything like that, the liver is going to inactivate it its first time going through the body. Now, we have other routes of administration when we're first giving this medication, like IV or sublingual. Those are the two fastest routes of medication administration. These normally bypass the first pass effect, so that's another thing to keep in mind. Now, when we're talking about distribution, so remember how I talked about, those little enzymes are going to help move things around your body so that your body can really do what it wants to do with the medications. So for the distribution, and it's pretty important that you know this, we've got three really, really big factors that contribute to distribution. One is going to be circulation. So if someone has a condition that's going to restrict blood flow or restrict perfusion, it's not going to allow medications to be distributed properly because it is distributed through our bloodstream after it's being absorbed, right? The other thing that we need to keep in mind is going to be the membrane permeability. So, in order for a medication to reach its target tissue or membranes or area of the body, it has to be able to break down into small enough pieces that it can pass through tissues and pass through membranes. So another thing to keep in mind is whether or not if a medication is lipid soluble or if it's water soluble. Those are the types of things that you're going to see, and it kind of gives a input into how it can be transported and distributed. Like for example, uh, lipid soluble medications, a lot of them, they have the ability to cross the placenta barrier, cross the blood-brain barrier. Another thing to keep in mind with distribution is going to be whether or not it has a plasma protein. Um, so when medications are competing for binding sites, plasma proteins like albumin is a plasma protein. Um, you have to keep in mind the degree in which a medication is going to be able to bind to a protein. All right, for metabolism, I talked a little bit about that first pass effect, but another thing to keep in mind is age, right? So an older individual might have some difficulty absorbing a medication, right? Because they're a little bit, people on the older side, they might have some kidneys and liver issues. So in order for them to be able to absorb it properly or distribute it properly without the risk of toxicity, um, they will normally need like a lower medication dose because, everything that's happening in their body, it can't distribute as fast, and then it's going to metabolize slow too, and then it's going to excrete slow. So that's why we need to give them a lower dose. And then for individuals who are really, really young, like infants, they have a limited capacity to metabolize medications. So they also need a lower dose for the same reason. Now, there are lots of metabolic pathways in the body. But if there is a medication that you're giving that, let's say, they're on the same pathway, like methotrexate and folic acid. Yes, you should take folic acid while you're on methotrexate, but should you take your folic acid at the same time as your methotrexate? No, because methotrexate inhibits the absorption of folic acid. So we want to take them separately from each other. Um, the other thing too is that if someone's malnourished, metabolism can also be affected because they might not have like all of the enzymes needed to help break down these drugs in their system. And then excretion. So excretion can happen in one or two ways, either filtration from the kidneys or it's excreted through your GI tract, right? Technically, also your exocrine glands, and your liver and lungs and can also eliminate medications, but I want you to keep in mind, specifically your kidneys and your GI tract. Um, a lot of impaired kidney function, so those are going to be your creatinine and your BUN levels, can happen from medications. For example, if someone has um, diabetes, right? They're at higher risk of getting kidney issues, and that's normal for them, just because their diabetes puts them at higher risk. But then if you give them NSAIDs, you have to make sure that you're monitoring their BUN, their creatinine levels, so that they don't get toxicity. Oops. Okay. So, a little bit more into some of the pharmacodynamics. So, agonists, these are going to be um, medications that mimic or help the specific system that they're trying to help out with. Like, for example, if it's a sympathomimetic, it's mimicking the sympathetic, thank you. I don't know why I said thank you, guys. I'm so sorry. Sympathetic nervous system. If they're an antagonist, it's blocking that. And then there are things called partial antagonists. You see them more, not more, but you're going to see them when we talk about the opiates and pain lecture. And I'm going to talk about different types of partial agonists, but they're both blocking and activating. They just might be doing it on two different receptors in the same pathway. So, therapeutic index. So, this is super important for when we are monitoring for those safer toxic levels, right? If something has a low therapeutic index, that means that the range of toxicity needs to be monitored more closely. A perfect example of this is going to be a medication called digoxin. Digoxin has a very, very, very narrow therapeutic index. So it's very, very easily for it to either not work or be toxic. Um, Another medication that you're going to see these therapeutic index or these peak and trough levels that you're going to have to do is going to be for vancomycin to make sure that we're keeping a therapeutic effect with this medication. And then there's medications like Tylenol or NSAIDs where you need to take a lot of them for them to become very toxic. And then we have half-life. So the one thing that I like to tell people is when something has a long half-life, and this is your medication that you're taking like once a day, right? So that's how long it takes for it to leave your system. If you have a pill that you take once a day, and it literally says on the bottle once a day, it's because it has a long half-life. Versus Tylenol, you can take it every 4 to 6 hours, so it has a shorter half-life. All right, so kind of going back to that general survey. When we're working on our CJM and we've taken observations from our general survey and we're starting to analyze those cues, um, you know, the cues of that high respiration, that bad smelling urine, that pain while voiding, and that altered level of consciousness, especially if they're an older individual, UTIs can cause altered levels of consciousness in older individuals. So that's how we get from, okay, here is our cues, here we go and analyzing them so that we can come up with a nursing diagnosis for our patient. For this one, it would be obviously infection, right? Would be kind of that blanket nursing diagnosis that we're going to do because they have an infection. All right. And then when we talk about prioritization, um, it's always going to be airway, breathing, circulation, right? So this individual, we're worried about their electrolyte imbalance, right? Because of the infection, or it could be risk for dehydration. So by prioritizing those problems, we know that what's most important and things that we have to monitor maybe a little bit more frequently, or maybe go back and, tell a provider, hey, X, Y, and Z treatment isn't working to maybe lower this individual's blood pressure. Maybe we should try X, Y, and Z. You know what I mean? Or if A, B, and C isn't working, let's try X, Y, and Z. That sort of thing. All right, going into some of the levels of framework really quickly, um, because this is going to be part of kind of that past medical history that you're going to get in the general survey. So stuff like what type of behaviors are they doing? If, they're coming in to get prep, are they do they have risky behaviors like sharing needles, or maybe they're a sex worker or something like that? Or are they an MSN? Other things like, did they get their immunizations? Did they get their Hep B? Did they get their HPV? These are all things that we need to know, and those are all going to be those primary um, prevention stuff. Technically, if they're getting prep and they have not modified those risky behaviors, getting prep is going to be a secondary prevention, technically. Um, I really like to think of it as a primary, but I think it's considered secondary because it's trying to prevent slash treat. But colonoscopies, mammograms, stuff like that, those are secondary because those are screening tools to see whether or not you have that disorder, right? And then tertiary is, okay, well, we did our screening for diabetes, we got our hemoglobin A1C, and now we're gonna put you on metformin as a pre-diabetic just to make sure that it doesn't go to full-blown diabetes. Doesn't ha I don't think it happens very often, but I've seen it in kids at least, where they have pre-diabetes. Maybe they have limitations to being able to do full um, lifestyle changes, so they might put them on antidiabetics to just help prevent further progression. Okay, so everything in nursing is going to be assess, then analyze your data, do your interventions, evaluate, and reevaluate. It's a continuous circle over and over and over again. So that goes along with our care plans, right? Even in our care plan, we're assessing our patient, we're analyzing them, creating our care plan, then we're going to do our interventions and reevaluate our patient to see whether or not the intervention helped. And that's the end of this section. I have other PowerPoints. We're going to go into the GI anatomy now. All right. Mhm. You can see this. Okay. So now we're going to talk about the gastrointestinal and the renal assessment. So remember, when we're talking about our abdomen, it's broken down into 9 different regions over 4 different quadrants. So we have our right and left hypochondriac, our epigastric, our right and left lumbar, an umbilical that's right above, right around your belly button, hypogastric, and right and left iliac position. Then we have our 4 quadrants. So when we are doing our assessment, remember, we're always going to start in right lower, go up to right upper, left lower. That's kind of following the direction of our colon. Our appendix is going to be in that right lower. Our right upper quadrant is really our liver and our gallbladder. Left upper, you know, spleen, pancreas, and our stomach. And left lower, is going to be that sigmoid colon as well as your ovaries. So this is going back to kind of that metabolism, absorption, all of that stuff, right? So when we're talking about the pathway of our GI tract, it's starting in the mouth, then we're going to the esophagus, the stomach, the small intestines, and then you go through the 3 portions of the small intestines. After that, you hit the large intestine. So obviously you have your ascending, transverse, descending, and sigmoid colon. After that, we have our rectum and anus. Its whole thing is being able to convert food into energy, move that now useless thing throughout our body for excretion, release the enzymes and all of that, helping break down those macromolecules. Digestion, remember, it starts in the mouth. The breakdown of carbohydrates start with your saliva. And then also the membranes, because our small intestine is really, really good at absorbing nutrients. It's going to absorb through your small intestine, send those to the bloodstream to help with really whatever we need it to do again. But like if it's a medication, a PO med, it's being metabolized, broken down, and then our small intestine is going to help it travel, just distribute all of that. So, when we're talking about food, I just finished talking about how, you know, food starts breaking down in your mouth. So that begins with chewing, that's the actual mechanical breakdown of food. And then you have your saliva, which it has enzymes in it to help chemically break down food. Specifically, we have amylase, and that's for carbohydrates, like I mentioned. As a result, we're going to have a bolus. That bolus is then going to go down into our stomach. And then once it mixes with our gastric juices, it's going to create chyme. And also chyme, your acid in your stomach also has some enzymes in it as well that's going to help break it down. But that food bolus is going to turn to chyme. And then once it's turned into chyme, it's going to go into the small intestines and we're going to further break it down and absorb it. So, like I mentioned, the small intestine, it does a huge portion of digestion and absorption, right? We have all the pancreatic enzymes, we have the bile. So, it's going to receive the chyme from your stomach, as well as the bile and the pancreatic enzymes right in that very upper portion of the small intestine, which is why when an individual gets their bile or their gallbladder removed, bile is just instead of being, stored in the gallbladder, it's shunted into the duodenum. So this is where a lot of that chemical digestion is going to happen. In our jejunum, this is where now that we've had that chemical breakdown, we're moving into nutrient absorption. And then again, with our ileum, this is really the rest of the liquid and stuff like that is going to be hopefully removed by this point before it gets into the colon. And then we're absorbing vitamins and stuff like that in the ileum as well. So our liver, again, it's producing bile. Bile's whole thing is being able to break down fats, which is why individuals who get their gallbladder removed, because we don't have that storing of the bile anymore, really have to be careful with how much fat they're taking in, because again, it's just shunted into their duodenum. So it's not released as as the presence of fat is there. Gallbladder, it stores and concentrates our bile. Our pancreas, it helps produce bicarbonate, so it makes our um, stomach acid more neutral if we need it to be more neutral. And then we also have amylase and lipase, which are the two marking indicators when an individual has pancreatitis. And then we have our spleen, which our spleen is an extremely important organ when it comes to our red blood cells, right? So it helps filter out those red blood cells and it stores all of our platelets and our white blood cells. Also, by filtering out those red blood cells, that is then going to turn into unconjugated bilirubin, which then with the help of the liver should conjugate. If it does not conjugate or improperly conjugates or there's some sort of break in the mechanism of action, this is how we see jaundice. And we see jaundice in a lot of little kids because obviously they have a premature liver, right? So this newborn jaundice that you see, they're not able to conjugate bilirubin, but in the presence of UV helps conjugate that bilirubin, which is why we tell people we're going to put them under the UV light, or when they go home, make sure that you're allowing them to go outside and let the skin hit their face because it helps with the conjugation of bilirubin in young kids. Now, can you put an adult out in the sun and expect their bilirubin to conjugate? No. Because at that point, if they have jaundice, that's just a malfunction in that pathway, right? Okay, so now moving into our renal system, it's GIGU. So our renal system is super important. Obviously, our kidneys are going to filter blood and produce urine. Our ureters, they help transport the urine. Our bladder stores our urine, and then our urethra helps us expel that from the body. So again, its whole thing is producing or being able to filter waste, filter blood. It's also going to regulate our electrolytes. It produces erythropoietin, which is a hormone that helps stimulate our red blood cell production. It helps activate vitamin D in the body for our healthy bones, and then it regulates blood pressure through the renin, angiotensin, aldosterone system. So here's the RAS pathway. So whenever we have low blood pressure or low amount of sodium, it's going to trigger the enzyme renin to release from the kidneys. Then from the kidneys, that enzyme is going to go to the liver, where renin is then converted into angiotensin 1. And then after being converted to angiotensin 1, we're going to go over to the lungs, where it's then converted into, or the lungs convert or have angiotensin converting enzymes in it to produce angiotensin 2, which causes vasoconstriction. And then it stimulates the adrenal gland to release aldosterone. And that whole pathway is how we get the vasoconstriction that causes the increase in blood pressure. So remember, vasodilation, our blood pressure is going to be lower. With vasoconstriction, it raises the BP because now it's kind of forcing itself through almost like a little straw. Here are some of the really, really big kidney functions or kidney labs to remember. We have our creatinine, urine albumin. Another one that you might see is something called UACR. That's your creatinine ratio in the urine. Your eGFR. Um, a really great way to remember your GFR is think of it as how well your kidneys are perfusing. So if you have CKD, your kidneys are not going to perfuse as well. So you're going to have a lower GFR. Now, the normal range is technically above 60, but in a very healthy adult, it's going to be above 90. All right. So when we're talking about kidneys, I also want to mention just a little bit about diabetic neuropathy because unfortunately, diabetes can impact it really impacts everything in the body, right? And the kidneys is one of those things that are also going to take a hit. So because of the super high blood glucose levels that you get in diabetes, whether or not it's controlled or not, they recently did a study that even, you know, early action of diabetes and regular glucose and insulin control, it still doesn't really do anything to prevent the diabetic neuropathy, unfortunately. Um, I don't know if they're going to do any more studies about that, but I think that's pretty interesting that even if someone who did all the things that they were supposed to can still end up with diabetic neuropathy. So, going back to the hyperglycemia. The hyperglycemia is going to cause the capillaries to become very stiff around the glomerular area of the kidneys. Then, because the glomeruli are so important for filtration, it's then putting too much pressure on that area, which impairs the filtration, and then it's going to cause the kidneys to not be able to waste things properly. Then after that, it's going to cause the leakage of protein, which then you get proteins in the urine. After you get protein in your urine, you're going to get inflammation and scarring, which then leads to permanent kidney damage like CKD. It's not just an AKI at this point. And then after that, you're going to get end-stage renal, CKD, and a reduced GFR, which goes with the CKD. All right. So when we are just looking at their abdomens, this is the visual portion of the head to toe, right? You're just looking at their abdomen. It's normal to see a smooth and even skin tone. It's normal to see symmetrical breathing. It's normal to see a flat or um, slightly convex abdomen. We should see an umbilicus that's either midline and inverted and a normal alternative finding, I guess is the good word for it, would be like an outie belly button. And then scars, striae, that's gray in color. And then a little, sometimes some pulsations and a little bit of peristalsis you should be able to see. We should see no bruising across the abdomen. Jaundice is not normal. If it's purple striae, it's indicative of something called Cushing syndrome or of someone who's rapidly gaining and losing weight at the same time. There's Cullen's and Gray Turner sign, which are signs of internal bleeding from, like uh, pancreatitis. And then there's also Murphy sign, and that's when you're palpating the abdomen around the appendix area, they get pain, but we're going to talk a little bit more about that. So here we go. I just talked about McBurney's point. That's the one that I was trying to talk about, McBurney's point. That palpation in the right lower quadrant. So Cullen's sign, that bluish discoloration around your belly button. Gray Turner's, that's on the flanks. And then Rothing's sign is when it's a sign of appendicitis. That's when you palpate that left lower quadrant and it causes pain in that opposite side. So don't forget that we're also always going to auscultate before we palpate. Um, and if you're listening in all of the quadrants, you should be able to hear 5 to 34 high-pitched gurgling sounds within 1 minute. You should timely be listening to each quadrant for a minute. So anything below 5 is going to be hypoactive, but if it's, completely empty, that's absent. Anything above 34 is hyperactive. Um, Also, there are times where you might hear like whooshing in certain areas of the body, like if you were listening over the um, kidneys in the back, and sometimes over the abdominal aorta, and that sometimes, but that is relatively indicative, that whooshing sign of some sort of aneurysm or stenosis. And then after we auscultate, we're going to palpate. Um, Obviously you're going to have to put some pressure, but when you're putting pressure, um, the lower you go, there will be some involuntary guarding that's normal. Um, but they're like not letting you touch it at all because it's just super painful. That's going to be abnormal. Or if they have a board like abdomen, that's abnormal as well. Um, any masses that are palpable, obviously abnormal. And then if they have any of those um, other signs, like we mentioned, the McBurney's point, um, those are also going to be abnormal signs of appendicitis. So, daily weights. So, the reason also we do daily weights besides for individuals who have heart failure, we're also going to do it for individuals who have kidney disease. And that's because we want to make sure that, because of the fact that they have kidney disease, they also have that fluid retention. Fluid overload is not only in heart failure, but the key here is that anything above 2 to 3 pounds in 24 hours or above 5 pounds in 1 week is going to be abnormal, and you have to notify your provider. Shortness of breath, that fluid in the lungs, frothy sputum, anything like that, we want to make sure that we document and we notify. So for our renal health, we have to make sure that we're maintaining adequate hydration, because urine output needs to be at a minimum 30 mLs per hour. Anything below that, it's called oliguria, and then anuria is the absence of urine. Absence of urine is commonly going to be seen in dialysis patients. Do also note that diabetes is the leading cause for dialysis in the United States because of the intense impact that it has on an individual's body. So, also, when we're talking about diet, if they need a renal diet, this is going to be low sodium. Sometimes it's also low potassium, depending. Um, and that also depends, kind of too on what diuretics they're on, right? Because if they're on a potassium sparing diuretic, it would make sense to have a low a low potassium diet. Versus if they were on a potassium wasting one. For GI health, it's going to be important to also not only maintain hydration, but fiber is also great. And then the probiotics, if they have been on like a course of antibiotics or anything like that, to help out with that healthy flora. So for exercise, this is going to help with motility. And, the standard amount should be about 150 minutes of moderate intensity, um, activity a week. So that could be as simple as, if it's me, I'm asthmatic. Sometimes walking up the stairs is enough for me to bring up that heart rate to a moderate intensity activity. So that can also count. Cleaning the house for some people. It's all dependent on the individual, and kind of their threshold to be able to do things. So medication safety, NSAIDs, we talked about them being nephrotoxic. And again, we're going to talk more about NSAIDs, their reversals and stuff like that, but also acetaminophen, that's a liver toxic medication. So these are medications that when a patient is on them, we're going to have to check those levels, right? Their LFTs or their BUN creatinine. Oops. All right, and then I have one more section for you guys, and it's going to be going over all of our GI meds. And there's a little bit of anatomy review in there too. So, we already went over this, so I'm not going to bore you on it again, but this is the big blueprint of how we get from the mouth to the rectum and how it works with, you know, being able to turn things into energy, absorb things, all of that. Here's our critical landmarks again, just so that you can remember them. And here's the importance of the renal system. So again, for our assessment, you want to make sure that you're looking at the expected versus the unexpected. Do they have bruits? Are there absent sounds? If we have absent bowel sounds, we're not going to want to give a laxative, right? Because all that's going to do is put like liquidy stool on top of a solid mass, and it's going to make the problem worse. This is the Cullen sign, the Turner's sign that's on the flanks. Um, there's the caput medusae. It's very commonly seen in portal hypertension, but that's dilated abdominal veins. And then again, that roasting wing sign where you touch the left side and it causes pain in that right side. So, talking about hepatitis. So, when we talk about our liver, there are technically 6 different types of hepatitis that you can get. So, you have hepatitis A through E that covers 5 of them, and then there's regular inflammation of the liver that's obviously has not progressed into like any scar tissue or anything like that. So cirrhosis is that scar tissue has been replacing that healthy tissue, and then they normally have that portal hypertension, and it causes esophageal varices and stuff like that. Very, very intense. Going back into hepatitis A through E, though, we have hepatitis A through C is more common in the US than D and E. D and E are not really ones that you're going to see in the US unless someone traveled to another country and came here. But in the case of D, you can't have Hep D without having Hep B. So you have to have Hep B. Um, Hep A is going to be fecal to oral route. Hep B is blood, bodily fluids, and babies. This is the one that nurses are most at risk for. Hep C, I like to think of it as, you know, you got C's in nursing school and you ended up with Hep C because you decided to do drugs that might not be a valid memorization trick. But that is how I memorized Hep C in school. Because it's shared needles, bodily fluids, blood, stuff like that. Intravenous drug use. All of those are for Hep C. Again, Hep D, you need a chronic condition of Hep B to get Hep D. And then Hep E, it's acute. And it's fecal to oral very similarly to how Hep A is. So, kind of going back into that portal hypertension and that cirrhosis, another thing that you're going to see with cirrhosis is going to be something called hepatic encephalopathy. This is when you have a decline in brain function, like confusion, stuff like that, because of the high ammonia levels. They also can get something called hysterics, which is a tremor where they kind of flap their hand around. But they are going to take a laxative called lactulose. It binds to ammonia to help pull it out of the body so that they're no longer confused. I use the trick lactulose makes you loose if you have liver cirrhosis, It clears ammonia, so you're no longer losing your mind. That might help you, I'm not sure. Then portal hypertension. This is that really big distended belly that people get with the really, really narrow legs. And that's due to an excessive fluid in the peritoneal cavity. Portal hypertension is on that portal hepatic vein, and that increase in pressure obviously is going to cause damage to that vasculature, and then that fluid is going to shift outwards. They may get a drainage in that peritoneal cavity, and literally they just like stick a needle through the abdominal wall into the peritoneal cavity and it drains out the fluid. And then it causes the bleeding risk. Again, I talked about that in increased liver size puts pressure then on your stomach, which then puts pressure on your esophagus and causes large distended veins. And any rupture is going to be a medical emergency. Think about it. You can't just slap a tourniquet on somebody's neck, right? It's going to keep them from getting blood to their brain. So that's why it's so important that when an esophageal varice ruptures, that they get immediate medical attention. So with our livers, babies are given vitamin K to help prepare their clotting factors, but in the case of these individuals, they may have impaired clotting factors. So we're going to monitor something called the PT-INR. Again, it's just labs for the clotting factors. And then we're also going to monitor their LFTs. So going into GERD, PUD, and gastritis, I really like to put these three together because they're very similar, but they have a few differences. So GERD, they have something called an incompetent sphincter. So that sphincter at the bottom of their esophagus, if they are, laying down, let's say they're laying down on their right side, it's going to allow backflow of acid into the stomach, which causes heartburn. A key sign with GERD, though, versus regular heartburn is that they're going to get regurgitation. So, that's really the difference between heartburn, and GERD. They have to have that regurgitation to get a GERD diagnosis. And then that sour taste in their mouth. We use something called manometry or an EGD to diagnose these. For gastritis, this is inflammation in your stomach lining. Sometimes it could be caused by a bacteria called H. pylori. It can also be caused by long-term NSAID use starting to irritate that stomach lining because, again, NSAIDs block that COX-1, COX-2, so it prevents that mucosa in the stomach from properly being coated. And then stress and alcohol can also do that for the same thing, that inhibition of the COX-1 and COX-2 for the stress, at least, of the prostaglandin synthesis. But they're going to have nausea, vomiting, and bloating. We're going to do the urea breath test. That is when a person is going to drink a very sweet solution. And then they're going to wait for a few minutes and they're going to blow into like a little test tube. This is checking for the presence of urea. If there is urea, they do have the H. pylori because the bacteria will take that sugar, they're going to ingest it, and then they're going to excrete it, causing their urea. And they also may get a biopsy. And then for PUD, these are actual ulcers that have formed in the stomach lining. People who take a lot of NSAIDs can get this. This is our upper GI bleed. Also, H. pylori can also cause this, as well as a lot of stress. So, these individuals, they get pain after eating, as well as they might have, again, it's that upper GI bleed, so they may have bloody stools, and they're also going to do that urea breath test. So, going into IBD, we have Crohn's and UC. Crohn's is anywhere between your mouth and your anus. They have something called skip lesions, so there are patches of healthy tissue and inflamed areas, and it's going to be transmural, so it affects all of the layers of the bowel, not just the inner mucosal lining. And then these patients, they are going to have non-bloody stools versus UC, they have characteristically bloody stools. And since it starts at their rectum, it is normal for them to have a very red, bright red, bloody stool. The higher up the GI bleed, the darker the stool is. So they would have very red stool because ulcerative colitis starts at the rectum and moves up through the colon, and continuously causes inflammation. But UC is more superficial and it's really just on that mucosal lining that's being damaged. So, a little bit more into that RAS pathway. We talked a little bit about it before and how it works. Those angiotensin converting enzymes that are in the lungs are going to help convert from angiotensin 1 to angiotensin 2. That presence of angiotensin 2 specifically, it's what causes that vasoconstriction. Very similarly to how when we are in fight or flight, we have the vasoconstriction, that increase in our blood pressure, and then that not vaso, but the bronchodilation that individuals get. And as a result, we will retain water and sodium. So think of your edema here, specifically your pitting edema when we are doing that assessment on the legs. They're holding on to all that water, and that's also going to cause the increase in their blood pressure. So I also like to put all in the same thing when we're talking about meds, the antacids, the H2As, and the PPIs, because they kind of work on the same kind of pathway, right? They're helping either like fully pause acid production or to help reduce that acid production. Um, Calcium carbonate, this is our standard Tums. It's calcium based, so you know, one of the biggest risks for someone who takes it all the time is going to be kidney stones. And then the, because again, it's calcium, it works on your smooth muscles in general, they can get palpitations. Magnesium hydroxide is another type of antacid, and it actually has a laxative effect. The other thing that you have to monitor for with magnesium is that with really excessive use of magnesium, it can cause respiratory depression, and a decrease in our DTRs. H2As, these are our Pepsid, and they help with a relatively short-term management of these GERD symptoms that you get. The other really cool thing about H2As is that they are commonly given when we have anaphylaxis to kind of help with that stomach and that excessive acid production, or if someone has like an increase in their mast cells in their GI tract. This is going to help lower that so that they don't have such a high acid level anymore. And then with that, they can get bowel changes like diarrhea and constipation is very commonly what we see with the Pepsid. PPIs, they're going to pause that acid production, and kind of irreversibly block it. The other thing to remember with our omeprazole is that they're going to block our very important bone electrolytes. So long-term use, they're going to be at risk for increased risk for fractures and osteoporosis. But because because we're blocking the acid production in GERD, and it's also used for PUD, and it's making the stomach more alkaline, our stomach is not going to be able to fight off bacteria because our gut flora is all messed up, right? And so they're actually at higher risk for getting a C. diff infection. All right, so when we're talking about nausea and vomiting, we've got two big ones here. We got metoclopramide, which also can be used in the OB setting, and we have Zofran. One thing to know about Zofran, especially if it's given, intravenously, because it does skip that first pass effect, is that risk for that QT prolongation. So this individual most likely is going to have to be on some sort of cardiac monitoring, just because we have to make sure that we're monitoring that. Yes, it's more of a rare side effect. But it is a side effect of the medication. So regardless, you should be monitoring them, especially if they have a past medical history or something cardiac related. This may not even be the best medication for them. But it's a lot of times going to be used in chemotherapy, induced vomiting or post-op vomiting. Um, and it works by blocking serotonin levels. Another medication is going to be Reglan. I talked about a little bit how it's used in the OB setting. It's actually used as a cervical ripener, fun fact. But one of the things that I could do is cause movement disorders like TD. It's also going to be contraindicated in SSRIs due to the increased risk of serotonin syndrome. And sometimes, even though it can be used to help older individuals eat, it can actually cause confusion and aggression in older individuals. But it's going to block dopamine in the same chemo-triggering zone as the Zofran. And it's also going to enhance the GI motility. So, you know, diarrhea is not really a uncommon side effect for them. All right. So moving into kind of the IBD medications and what they do. So the whole thing with our IBD medications, we're trying to reduce inflammation. One of the things that we're going to use to reduce inflammation is prednisone. However, with prednisone, if they are diabetic, we have to make sure that we're monitoring the blood sugar levels because it causes your liver to release stored glucose and it kind of blocks your pancreas from being able to supplement with insulin. It also causes osteoporosis and it can lead to something called Cushing's disease, which is, high blood sugar, hypertension, stuff like that. You have your 5-ASAs, which help block your prostaglandin synthesis and your leukotrienes. Another leukotriene modifier that maybe you've probably heard of before is going to be Singulair. But they're going to help reduce the inflammation in the intestinal lining. Then we have biologics. So this is our infliximab or adalimumab, and these are blocking certain parts of the immune system to, well, biologics. So anything ends in mab. Their whole thing, ironically, is even though they are trying to support your immune system, they're actually going to decrease your immune system, right? Because these are chronic conditions, these are immuno conditions. So your own immune system is fighting itself, which is why we decrease their immunity when we give it to them. It suppresses their immune system. So if someone has oral thrush or if they're showing it a fever, really any signs and symptoms of an infection, they should report them. Immunomodulators, the same thing. Any signs of symptoms of infection, they need to report. One thing with methotrexate, and I'll talk more about this when we go into RA, is it can cause something called bone marrow suppression. So we have to make sure that we're monitoring their like blood counts. Also, because it inhibits folic acid, we have to make sure that we are taking a folic acid supplement. But like I mentioned before, we don't want to take them at the same time. So here's a little bit of a case study. We have a male, he's been brought into the ED. He's a little bit confused and disheveled. We kind of saw the beginnings of this earlier. So we see his vital signs, and the findings is that he's confused, he has body odor, and he is facially grimacing. Again, he's altered mentally, and there are some things here that are suggesting that he does have an infection. A really good indicator that there's some sort of a urinary tract or renal involvement is the fact that his urine is that dark brown. So we are going to make sure that we start getting labs on this patient. We're going to report our findings to our provider, and then we're going to give them fluids because that color that urine is. Not good. And then we're going to give them broad spectrum antibiotics. Obviously, culture first. We'll talk more about that in our anti-infectives lecture. Culture that first, make sure that, they have the right antibiotic for whatever UTI they have. And then to bring down that fever, we're going to give them Tylenol as well. And that's also going to help with some of the grimacing that they get, that pain that they get. This individual, we're going to have to monitor their urine output. So making sure that they have at least 30 mLs per hour. Um, it may be strict, it might not be. Strict would be like catheterization and then making sure that, everything that we put in them fluids wise, we're monitoring and documenting. Um, and then the full breakdown is going to be, in elderly people, it's pretty normal to see that acute confusion and um, that fever from the UTIs, especially if they're progressing to urosepsis. With the name, we should be able to tell that urosepsis has a risk of an AKI, as well as dehydration. And that is all I have for you guys. This has been the GI. We have gone over um, the general survey, GI meds, the GI assessment, as well as some pharmacokinetics, vital signs, and all of that in here. And thank you so much. And can't wait for you guys to hear the next one. The next one's going to be integumentary, nutrition, medication administration, and pressure wounds.